DCS on your rhythm. Supplemental oxygen, it says to maintain it greater than 90, preferably greater than 94, and prevent it from getting below 90. So even when you're intubating, make sure you pre-oxygenate so there's enough oxygen in the system that it doesn't drop off the cliff when you're intubating. Advanced would do an IVIO and then cardiac monitor, and then you jump into whatever protocol you need to jump into and how you need to treat it. And then there were the drug-assisted airway ones, which I know won't apply to you guys. But IVIO, you pre-oxygenate completely, have another airway available. So have a key airway ready in case your intubation fails. Be the one we carry locally anyway. Have everything ready to go, have it all put together. So kind of like we've done with key airways. You have it all put together so when you're ready to drop the tube, you're not fumbling around with stuff and wasting time. Right before you do it, you're going to handle the etomidate, which is 0.3 milligrams per kilogram. Then you're going to follow with the succinylcholine, which is 1.5 milligrams per kilogram. Intubate, and then verify with capnography. Actually, let me go back one slide. I did see this. So do not routinely hyperventilate. They used to talk about with head injuries, you could breathe faster for them because of the potential for herniation. Now they want you to have evidence of the herniation before you start hyperventilating. And what they talk about in our state protocol is a unilateral or bilateral dilation of the pupil and the posturing. So they start having that decorticated decerebrate posturing, flexion or extension, start thinking about it. And then it says you can drop your ETCO2 to, excuse me, 30 or 45. I'm sorry, 30 to 35. So you drop it a little lower to help with that herniation. All right, first of all, before we summarize, any questions about anything? So as a basic, what are you going to do? You're going to maintain airway, maintain ventilations, possibly hyperventilate based on your CO2 presentation. You're going to rapidly transport, C-spine precautions. Yeah, I think that's about it for you guys. Call ALS, get them there. Not that there's a lot more that we're going to do, but we can do the IV access to maintain the pressures, to help maintain that perfusion. And some of you, actually most of you in this room are planning to either become PAs, physician assistants, going into something else medical after college. And if you work in an emergency setting, you may eventually see some of this. Now, if you work in a regular doctor's office, hopefully you won't see a lot of severe TBIs because you'll be calling 911 if you do. But the TBI, what we worry about is it increases your intracranial pressure. Body regulates it by changing map pressures and dilations, which can cause that cycle where the increase in blood flow increases ICP and it keeps going. If it gets too high, we can get herniation, where part of the brain matter is pushed down and out of where it should be. And the biggest thing we can do is recognize it and get them to the right place quickly so they have the best chance of survival with no deficits. Any questions? We're good? Thanks, guys.